Good evening, everyone. My name is Dr. Mazhar Amir Ali. I'm a physician and nephrologist and country medical director for Africa Healthcare Network, for those who don't know me. Today, we are going to have our Fireside Chat number 170, but also this is going to be the second part of our peritoneal dialysis webinar series in collaboration with the International Society of Nephrology, International Society of Peritoneal Dialysis. I'm just giving a short introduction, but our moderator for the session is going to be Dr. Brett Cullis, who is a nephrologist and a specialist intensive care physician at Hilton Life Hospital, and is an honorary associate professor of nephrology at the University of Cape Town. He is a co-author of the ISPD guidelines for optimal PD access and the current PD catheter infection guideline. He was lead author for the ISPD guidelines for PD in AKI in 2015 and 2020. He is the chair of Saving Young Lives program and sits on the ISN Core Programs Committee, ISN Africa Regional Board, ISN Dialysis Working Group, ISN WHO AKI and Dialysis Toolkit Development Group, and is on the ISPD Council. We are very grateful for a great panel that we have, and I'm now going to hand over to Dr. Cullis to take over. Thank you so much. Welcome.
Thank you very much, Mazhar, and for AHN for inviting me to moderate this talk. We've got two fantastic speakers today. The first, I'm going to introduce them separately when they give their talks, but the first is colleague and friend, Dr.Lily Mushahar. Dr. Mushahar is the head consultant nephrologist at the Department of Nephrology at the Tuanku Jafar Seremban Hospital in Malaysia, but also head of Clinical Research Center Negeri Sembilan. She trained in Malaysia, but also did fellowship at the North Staffordshire Hospital at Stoke-on-Trent, and many of us know this is the holy grail of PD education. So she comes from great centers. She sits on many committees, but she's president of the Malaysian Society of Nephrology. She's the chair of the membership committee for the ISPD. She's the chair of the CME committee for the Asia Pacific Society of Nephrology. She's also committee members of the ISPD Awards and Scholarship Committee, as well as the ISPD Asia Pacific Core Group. She's a supervisor for training ISPD members and ISN Sister Renal Center trainees in Indonesia. She's also a mentor for the International Society of Nephrology Mentorship Program. And no one could be better trained and have as much experience as Dr. Mushahar to talk about peritoneal dialysis catheters and management thereof. So I'd like to introduce you and give us your talk. Thanks very much.
Thank you, Brett, for the kind introduction. Good evening, everyone. First and foremost, I would like to thank the AHN for inviting me, for having me here today to share with you with my talk on the catheter troubleshooting for nephrologists and nephrology nurse. This is my disclosure. As you all know, the PD catheter is the Achilles heel and the only access for PD patient, as compared to the hemodialysis, where if you have problematic vascular access, you can put in a dialysis catheter either in the IJC or femoral. But for PD, is only in the abdomen or tummy and intraperitoneally. And the success of a PD catheter placement is the first step to determine the outcome of a PD therapy. And the PD catheter placement can be performed by a nephrologist, interventional radiologist, or a surgeon who is trained and skillful. When we talk about the PD access achievement, the main thing is actually the timely placement of PD catheter. Because if there's a long waiting list for PD catheter placement, then the outcome in terms of the patient going to be on the temporary hemodialysis while waiting for the PD catheter insertion will be longer. And this sometimes can lead to the patient to change their mindset of continuing to be on PD, and they may want to convert to hemodialysis. The other thing is the target for PD access achievement is low morbidity and mortality, which is related to the procedure, in terms of the absence of complications to the patient intraoperatively or having a visceral injury, and the absence of early and late complications post-operatively, which I'm going to allude in later in my talk. And the other thing is to have an excellent PD catheter outcome. The first thing is to make sure that the PD catheter actually works, and also to have being patent and able to maintain a good catheter survival. In terms of the techniques of PD catheter insertion available, is either you can have open surgery, percutaneous needle guide wire or cell ginger, peritoneoscopic method or laparoscopic. For your information, in Malaysia, more than 80% of our PD catheter are being inserted by the nephrologist, which is either by peritoneoscopic method or the cell ginger method. However, there are certain cases of patients that we tend to refer to the surgeon, especially the complicated ones, if that we anticipate hernia or repair. And another thing is if the patient has a very pendulous abdomen and it's going to be a challenging PD catheter insertion when we insert percutaneously. When we talk about complication of PD catheter, we need to know can it be either mechanical or it can be also can be due to infectious condition. And in terms of mechanical, like I mentioned just now, we have to make sure that the PD catheter is patent. So therefore, the flow must be good in terms of absence of flow dysfunction and also leakage issue. And the other complication of PD catheter is infectious. When we define the PD catheter complications, it can be either early complications or late complication. And the definition of early complications when is defined as early as less than 30 days after the PD catheter placement, where usually it can be bleeding, perforation, pericatheter leaks, or catheter obstruction and infection. Whereas late complications that is defined where the onset is more than 30 days after the PD catheter placement. So let's go what are the possible troubleshooting by the nephrologist and the nurses which is related to the PD catheter complication. The first thing is bleeding. Whenever we see intraoperatively when we insert a PD catheter, you can, if you notice that a blood stain PD solution or drainage, then we have to think of whether there's evidence of due to vascular injury. And the incidence of vascular injury intraoperatively is about 0 to 7.5%. It has been reported, and mainly is either because of anticoagulation treatment which has not been withheld prior to the surgery. And the other thing, complication to vascular injury, which is more severe, is the inferior epigastric artery injury. And the clinical presentation is either the patient suddenly complain of severe intra-abdominal pain intraoperatively or immediately post-operatively. And you will notice that hemodynamically that the patient are unstable and they develop hypotension. And when you drain the PD fluid intraoperatively, you will notice that either the patient will have a slight blood stain or heavily blood stain PD drainage. And how will you manage this inferior epigastric artery injury? The first thing is you need to refer to the surgeon, because the nephrologist, if the PD catheter procedure insertion is being done by the nephrologist, we need a surgeon backup. And we need to refer to surgeon immediately in the OT, and the surgeon is either can ligate if noted intraoperatively there's an injury to the inferior epigastric artery, or if post-operatively being discovered there's a bleeding intraperitoneum, then we can refer to the surgeon. Either they can do surgical versus angiographic embolization if discovered post-operatively, as you can see from this angiogram, which revealed the extravasation from inferior epigastric artery after embolization. Therefore, to prevent when you perform a PD catheter insertion, how should we avoid the infraepigastric artery injury? And the choice of the site, it actually is operator dependent. Some will decide on whether they want to have a midline 2 centimeter inferior to the umbilicus, and we can infiltrate the local analgesic into the rectus sheath to use a varus needle or a local LA needle to check for any flashback due to underlying blood vessels injury. And the other thing is what I tend to do, the nephrologist here in Malaysia, majority of us are doing a paramedian incision, which is a 2 cm lateral to the paraumbilical area. The second complication, the troubleshooting, is if you notice there's a fecal matter in the PD dialysate. And this usually occur, the injury if perforating the bowel or viscous, which is about 1%, and usually occur when we advance the catheter into the pelvis. As you, maybe, I'm not sure how, because if the surgeon, there's a direct view, but when we do a peritonoscopy or salvage method, we might injure when we advance the catheter or the needle. And sometimes you can see visualize the bowel content and the dialysate fluid, which is the PD fecal matter, or you can smell a foul smelling gas in the OT. So that is a clue that you might injure viscous. The other perforation that we tend to occur is the urinary bladder injury. And this, you will notice that when there's an increase in urine volume, where the patient feels that the bladder is distended, and immediately after installation of the dialysate, and when the patient pee or passing urine, you will notice that it looks like a PD dialysate coming out. And the management of this, when there's the bladder perforation, is actually to refer to the surgeon immediately. Another thing of we have anticipate the complication of PD catheter insertion is pericatheter bleeding and hematoma. And this is actually can happen as an early complication immediately post-operatively. From this photo, you can see that there is either pericatheter bleeding, which is oozing, and the more serious one, as at the right-hand picture, is where there's blood clots, where despite compressing with pressure, the bleeding would not stop. And this either because of the tunneling, where it might hit some blood vessels subcutaneously and at the exit site. And the blood may present initially when you drain the PD catheter, and also due to the trauma of the insertion. You need to flush with the PD catheter until the dialysate is clear. However, if continuous flushing does not resolve, then you may need to refer to the surgeon to get their assistance in identifying where is the source of bleeding. If it's a very minimal pericatheter bleeding, then the first thing that you should do is giving an adrenaline pack with manual compression. And the point of compression must be exactly at the place where you think the bleeder is either sometimes an injury at the blood vessel at the exit site or along the tunnel. And if this just a very minor bleeding subcutaneously, but just by doing a manual pressure, it can stop the persistent bleeding. Please do not add additional suture. You should not suture at the exit site to stop the bleeding, because this can cause introduced infection. And you need to check the hemoglobin and correct the patient's anemia. If there's significant bleeding, you may need to have a blood transfusion done if the hemoglobin dropped significantly less than 8 grams per deciliter. So like I mentioned just now, so this is a photo where someone has actually did an additional suture which is quite tight, and this actually can introduce infection at the exit site in the future. The fourth troubleshooting is when the PD catheter does not work and it is not patent, and this is due to the PD catheter obstruction. So the PD catheter obstruction can be either inflow obstruction, outflow obstruction, or it can be both. When there is an inflow obstruction, it is due to a mechanical blockage, where during the PD catheter placement, the operator actually create a kink in the subcutaneous tunneling, and this actually can occlude the segment under the dressing and cause inflow obstruction. Another thing of reason when there's inflow obstruction, where intraluminally of the PD catheter, there's blood clot or debris or fibrin. And fibrin or debris usually occurs with when there's ongoing infection, but the thing that we can do is we can't flush the inflow obstruction, then we should perform an abdominal X-ray to see whether there's any anatomy abnormality of the PD catheter being done. When there is outflow obstruction, it is actually can be due to a mechanical blockage of the transfer set or the catheter, or also it can be due to the post-implantation blood clot or fibrin. When we perform a Seldinger or peritonoscopic method, usually it's bloodless. There's very minimal bleeding. However, if it's a traumatic PD catheter insertion, the blood clots actually can cause obstruction intraluminally, and the inflow and outflow will be you're having a problem when you flush. Another outflow obstruction causes is whether it's because of extrinsic bladder compression due to urinary retention. And another common causes is actually the catheter tip actually have migrated out of the pelvis, or because of the omental wrap causing the catheter entrapment, and also adhesion can also cause outflow obstruction. This is a photo which shows the intraluminal debris. It can be either fibrin or it can be due to blood clots. And the fill and drain, the debris actually, you can actually flush with irrigation and saline. And some operator, they use wires where they under fluoroscopic guidance, where they insert the guide wire in through intraluminally to dislodge this debris. The other thing is how we should manage of slow fill or slow drain, where there is no obstruction. You can still flush the PD catheter, but the drain is quite slow. And if you want to define what do you mean by slow fill and slow drain, usually when you fill in a PD solution intraperitoneally, the ideal time of the flow rate to empty the 2-liter bag is about 10 to 15 minutes. That means that there's no problems with the fill. And the outflow for the intraperitoneal after the dwell time actually is about 20 to 25 minutes. However, if the inflow or outflow drain is prolonged, maybe, for example, 45 minutes, even though the patient's trying to, sometimes they do a shaking maneuver to fasten the outflow, it will still not work. Therefore, when this occurs with a slow fill or slow drain, then you should think whether there is actually some problem with omental wrap or catheter entrapment. So when you have encounter a slow fill or slow drain, or even there's a problem with the patency of the PD catheter, the first thing that you should perform is imaging, which is the abdominal X-ray. And on the left-hand side of this X-ray shows that where the position of the PD catheter tip should be. It should be within the pelvic cavity, in the pelvis. On the right-hand side, when it's a film of imaging, we showed the PD catheter actually migrated above the pelvis into the right hypochondrium. So this actually is a migrated PD catheter. And the reason why the PD catheter tends to migrate is either because of the omental wrap, where it pulls up the PD catheter tip and causing entrapment of the PD catheter. And another possible causes of why there's omental wrap, sometimes there's also adhesion at the suturing site, which cause the obstruction, where on the left-hand side it shows that someone actually has done a omentopexy, where the PD catheter has been sutured to the pelvis, and this actually caused a take-up point and causing obstruction. How do we manage a migrated PD catheter? Whether you want it or not, the only thing that we have to do before we refer to the surgeon, or we remove and reinsert, is we prescribe laxative. In a patient who has constipation, the PD catheter tend to migrate. So we prescribe laxative regularly, which is either syrup lactulose, 15 ml BD or OD, to ensure that the patient has a good bowel opening. And if that doesn't work, then we should proceed for a catheter salvage or remove and reinsert a new catheter. To save time, what we do in Malaysia, we do at the same setting, where we remove the PD catheter and we insert a new PD catheter at the same setting. In view, sometimes it's difficult to have an operative time. If the laparoscopic view showed omental wrap, some surgeon would do a catheter alignment, and it's either they remove some of the omentum and omentopexy are being done. So what are the tips to prevent catheter migration? You need to know that our PD catheter has a memory shape memory where it tends to force the PD catheter to flip because it follows the orientation of the way that is being manufactured. And the PD catheter is either a straight PD catheter or a coiled PD catheter. We tend to use a coiled PD catheter as which is more less catheter migration we tend to observe. And when you put a PD catheter in the peritoneum cavity, you have to ensure that the tip have to be at the symphysis pubis. And the alignment, as you can see here from the photo, this cartoon, showed it has to have an arcuate angle. What do you mean an arcuate angle? Is actually an inverted U. And this subcutaneous segment may be implanted during intraoperatively, and it actually enable the catheter exit to be caudally or laterally directed, and this actually less risk of catheter migration. The next troubleshooting is dialysate leak, post-PD catheter placement. And the incidence of dialysate leaks actually includes the leak through the exit site. It can occur into the pleura, and the patient, in a male patient, it can occur in the scrotal swelling where there's patent processes vaginalis or abdominal hernia. And the incidence is about more than 5% during treatment with CAPD in many of the studies which have been shown. And the risk factor for related to the dialysate leakage in PD is either because of the technique of the PD catheter placement, especially if the higher risk if you insert the PD catheter in a surgical placement versus a paramedian insertion. And another risk is initiating the PD therapy, instilling the PD solution early or urgent start PD, which is less than 14 days traditionally. And in patients who are obese, we tend to see, an elderly, the dialysate leaks tends to be more in urgent start PD. So therefore, in initiation of PD catheter of a PD in early or urgent start PD, we should instill a lower volume, and slowly we incremental it, the PD solution volume after more than 14 days. Another risk factors to dialysate leakage in PD is because of the abdominal weakness, especially in elderly, or if the individual has previous abdominal surgery, or poor wound healing and abdominal obesity or hernia. How would you troubleshoot a pericatheter leak? So this is a patient on the left-hand side. After 1 month of PD training, we noticed there's some leaking at the exit site. And to verify whether this is actually a pericatheter from the leak from the PD solution, how you should verify is to use a glucose test strip, where you put a glucose test strip at the leak and the blood sugar shows 19, whereas the patient's blood sugar maybe is, when you do a finger prick, is about 6 or 10. And this shows that the leak actually comes from the PD solution. And you should examine and document the condition of the exit site and tunnel. You can apply alternate dressing, and also to accommodate the increased fluid drainage. And again, similarly to a bleeding of the pericatheter, do not suture at the exit site. The exit site should be free of suture. In view, you can introduce at the exit site infection. As you can see here on the left hand photo, there's some inflammation at the exit site, and there's someone had actually sutured at the exit site. So again, for pericatheter leak, do not suture, and we should rest the abdomen in terms of to heal the leak. Sometimes the rectus muscle, especially in the elderly, when you implant the internal cuff, it will not heal well. So we have to delay the PD training and instilling the PD solution. This is another troubleshoot, that when the patient is on PD therapy, you can see some halo or subcutaneous swelling in the abdomen. And this is actually a result of a pericatheter leak at the insertion of internal cuff, or dissection of the dialysate into the abdominal wall. So you should examine the scrotal area penile or labial swelling because the leak can actually extend to this region. And the patient may present with a reduced ultrafiltration when they have the leak of the PD solution, and they will gain weight because the poor ultrafiltration, they will gain weight, and sometimes they develop lower limb edema. So how we manage the pericatheter leak and subcutaneous leak? To reduce the leak is either you can use dry day. If the patient is on automated PD, then when they lie supine, we can instill a very low volume dialysate exchange where we can initiate with 500 ml dwell volume rather than rapidly train the patient with a 2-liter PD solution volume. To keep the dry day also, we can temporarily suspension the PD for 4 to 6 weeks. So the patient may need a rest of the PD therapy for at least 4 to 6 weeks, and we may need to put on hemodialysis. The other thing is we need to delay the PD training if the patient is not anuric and may require temporary HD. However, if the patient still has urine output, we may not require the patient to be on temporary HD, but advise the patient to control their PD, to control their fluid intake. So to delay for that 4 to 6 weeks, so before we can restart the PD training again. To ensure the patient doesn't develop exit site infection or PD peritonitis, whenever there's a leak, we should start prophylactic oral antibiotics for at least 3 to 5 days. How can we prevent a pericatheter leak and subcutaneous leak? The main thing is actually to delay the catheter break-in procedure, where traditionally we trained the patient PD training after 14 days. However, if you need to start an urgent start PD, which is not the conventional way, where you need to start maybe 48 hours of PD catheter insertion, then you need to have a low volume PD exchanges with the patient in supine position. This is another catheter leak where there is a fracture in the PD catheter. This is our patient, a young patient who has been on PD for 3 years. And we noticed that there's a leak at the circle there, which is about 5 centimeters away from the exit site. And rather than to remove the PD catheter and reinserting a new one, what we did is we create a bridging with a titanium connectology, where we connect with a titanium to a new PD catheter, and we cut inferiorly to the exit of the we cut inferiorly to the leak, and we extend with a titanium. So this is one way where the patient doesn't need to undergo operative procedure to remove the catheter, but it's just to bridge the new catheter with the old catheter using a titanium. So how you confirm the leaks? We should perform imaging, which is a CT scan with intraperitoneal contrast, and or MRI imaging without gadolinium. And this is the protocol to perform a CT peritoneum, where you need to instill a contrast to fill the abdomen with a 2-liter peritoneal dialysate mixed with at least 100 ml of isoosmolar contrast. 2 hours later, after we allow the patient to walk around, then we repeat the CT, and you can see there's extravasation of the contrast into the subcutaneously, and this actually confirms the leak. This is just to show you that whenever the patient is sitting, the intraperitoneal pressure is much higher as compared to supine. And so therefore, whenever there's a leak, we should it's better for the patient to undergo PD if the patient in a supine position rather than sitting position. Okay, so sorry, this is a repeat. Another thing is in terms of troubleshooting, when you see there's extrusion of the PD catheter cuff. Here, you can see that the cuff is exposed, and there's also ongoing exit site infection. And this is because the cuff actually can introduce infection at the exit site, and later subsequently can cause PD peritonitis. So the PD catheter external cuff should be embedded at least 2 centimeters subcutaneously away from the exit site. And this is very important in terms to avoid extrusion of the external cuff. And how we should do it is when you plan a PD catheter insertion, like I mentioned here, if you can see from the graph, that it actually need to be at least 2 centimeters away of the superficial cuff from the exit site. And the exit site should face downward and lateral. And this is to avoid from dust or sweat to accumulate at the exit site to lead a risk or high risk of exit site infection. How will you manage? If you see there's external cuff extrusion, you have to cauterize the excised skin to expose the distal cuff, and you debride the cuff away, or we call it shaving of the external cuff. So here you can see that external cuff actually has been shaved and exposed. From the ISPD catheter insertion guideline in 2023, that it has been shown that the proportion of PD catheter insertion related infection should be less than 5%. So therefore, we have to take precaution and prophylactically providing or giving the patient antibiotics to prevent catheter infection. And this is especially in patients who have break-in catheter. So this is a patient who has an exit site infection. And whenever a nephrologist or the PD nurse see this exit site infection, you can see there's also a granuloma. And to manage an exit site, we have to take an exit swab CNS, and because in view the most common organism is Staph aureus and Pseudomonas, so we have to treat with antibiotics appropriately. And for the granuloma, we can use cauterization using magnesium silicate to put at the granuloma area. And this is just to show you how to prevent exit site infection, where the proper way is to face downwards and laterally and not upwards or caudally. And this is one way of how to prevent exit site infection in terms of dressing, where we can either do a topical, it is compulsory that we should apply a topical mupirocin or gentamicin ointment application at the exit site. Depends on the microbiome of your PD center, or what are the common causative organism. And the other thing is we should apply also dressing at the area, and also immobilization of the PD catheter to avoid mechanical stress. Some centers, we do perform non-dressing of exit site, especially in countries where it's humid and that the PD catheter dressing may be soiled. So we do perform non-dressing of exit site after 3 months of PD catheter insertion, once the PD catheter exit site actually has healed well. And this actually has been shown has reduced our lower risk of exit site infection. A novel way of technique whenever there's an exit site infection to avoid catheter removal is catheter splicing. So I think maybe this is quite a complicated diagram, but just to summarize that what do we mean by splicing is to remove or relocate the exit site in a new area opposite the abdomen. For example, if your exit site existing exit site is on the left abdominal region, and the patient had exit infection, we can actually relocate and perform a catheter splicing to reposition the exit site on the opposite area using a titanium extender. And from this method, actually, Fukasawa, who have performed at least 22 patients who had undergoing exit site, actually it reduced, did not recur of the exit site when they relocate the exit site. Another way of paper which Kirmizis also showed that from the result of relocation of the exit site, 74% of exit site actually resolved. However, 26% of the catheter need to be removed due to recurrent exit site infection. The next one is tunnel infection. If you can see from this photo, if you notice there's a bulging area at the tunnel and inflamed, And this is because of the presence of inflammation or ultrasonographic evidence of collection along the catheter tunnel. And if you notice this, the best way is actually to treat with antibiotics and to remove the PD catheter. But if the PD catheter is a precious PD catheter, and another way is either you can also do a de-roofing. The photo from this on the left-hand side showed that being done to avoid removing the PD catheter, and you can see that the internal cuff the external cuff has been exposed, and the patient has to go undergoing regular dressing until the granulation tissue has well healed, and subsequently you can do a secondary suturing, or if the granulation heals very well, the patient actually can avoid undergoing secondary suturing. So in conclusion, PD catheter complication is an important factor that contribute to patient morbidity and technique failure. So there's many, you can see that there's a lot of PD catheter complication that you tend to see post-operatively is either immediate or late, which is defined by less than 30 days or more than 30 days. So therefore, troubleshooting by identifying and preventing and managing optimally the PD catheter infect complication is crucial in terms of to ensure that the patient PD catheter survival is good and have a better outcome in your PD center. So with that, I thank you. Before I end, I would just like to highlight that in 2025, Malaysia will be hosting the 11th Asia Pacific chapter of ISPD Congress in Kuala Lumpur on the 3rd to 6th September. So I welcome all of you to join us in this Congress. Thank you.
Thank you very much, Dr. Mushahar. That was a fantastic talk. And what you highlighted is that although there are a number of complications of PD catheters, there's also an answer to every one of them. And we can salvage most of these patients. They don't need to move on to hemodialysis just because they've got a complication. I just want to invite everyone, there's a Q&A box if you'd like to submit questions. Dr. Mushahar, it is 12:30 midnight for you or 1:45, so we won't keep you too long, but there are a few questions, if you don't mind, just us asking. The first thing I just want to ask from my perspective, in Malaysia, you've got good evidence of improvement in numbers of patients going onto PD when your nephrologist started inserting PD catheters. And what advice would you give to doctors in Africa who are wanting to set up centers as nephrologists? How do you convince people that you should be allowed to put the PD catheters in? Because certainly that's probably the only way that we're going to expand PD.
Okay, thank you, Brad. I think it was in year 2004 that I was one of the pioneers in Malaysia to insert the PD catheter by the nephrologist. And we inserted the PD catheter during that time using the peritonoscopic. So we bought a peritonoscopic set. And I think the most important thing, how to ensure to get the nephrologist to put a PD catheter, number one is motivated and passionate to do the procedure. Not everyone likes to do procedure. So you have to select someone who really are passionate to do it. And of course, usually you have to train the young ones. And the other thing is when you want to introduce the nephrologist to cross the boundaries of a surgeon territory, it was quite challenging for us initially, where the surgeon would not allow us to go to the OT. They said the abdomen is our territory, nephrologist should not insert the PD catheter. However, we met up with them. We invited them into the OT when we do the PD catheter, and then we told them actually we are lifting the burden from them. And when they observe that it actually is the cell-ginger method or the peritonoscopic method is not very very challenging, and they doesn't require GA, general anesthesia, so we just need some local anesthesia and some sedative, where we use fentanyl and midazolam. So subsequently, they noticed that when we show the outcome is very good, then the surgeon actually allow us to go into the operating theatre and to perform the PD catheter insertion. And the other thing is very important to get your team in. So when we perform the PD catheter insertion by the nephrologist, we bring our PD nurse in. This is because the OT nurse may not be familiar of hanging the PD catheter, hanging the PD solution and flushing the bag. So we brought in one PD nurse into the OT to assist us. So it is actually a team, and the OT nurse just help us in terms of giving the providing the OT sets. So I think that is the one of the most important thing, that how to initiate a program of PD catheter insertion by the nephrologist.
That's fantastic. And I mean, I completely agree with you with the surgeons. Certainly that's been my experience. You know, you want the surgeons on your side so that if you do have a complication, they will be supportive of you. So you do need to approach them beforehand.
Yes.
But as you said, what you're trying to, the way to convince them is actually to say, look, you're going to take the easy cases and leave them to do the stuff that surgeons do. You know, they feel like you're actually relieving them of work. And I think that's really helpful. So thank you for that. Tell me, there's a question here just about flushing. So do you flush your PD catheters afterwards? And if you do you add heparin or don't you?
No, because we perform a peritoneoscopic method. I mean, in our center, for information, we have 400 PD patients in our center, and we perform peritoneoscopic method, and actually it's quite bloodless. From skin to skin, we can, it's about 20 minutes. So when it's bloodless and less traumatic, we do not flush at all. We just instill about 500 ml of PD solution just to check the patency. And then we check the flow in and out. So like I mentioned just now, when you see at the flow is quite good, then we well at least 200 to 300 ml of PD fluid into the abdomen. We didn't flush out totally to keep it dry, because we do see that when we dry the abdomen post-operatively, the catheter tend to migrate. So we keep at least 200 ml of PD solution in the intraperitoneally before we close the skin. We do not require to have the catheter being flushed in the wards. We have stopped doing that for more than 10 years. We do not want to manipulate the PD catheter and the dressing. So the only time that we flush is actually intraoperatively, which is that during that few minutes. So we do not flush. However, if you do see some blood-stained PD solution or dialysate, maybe there's some trauma or injury, then you may need to flush until the PD solution are clear. And maybe in the ward, some nephrologists, I do see in Malaysia, they practice of flushing just to ensure that the PD solution are clear to avoid blood clots. So that is very, very rare.
Great. I mean, we do. So I do Seldinger technique. I haven't ever used peritoneoscopic, but it's very seldom that you get bleeding.
Yes.
Much more common when the surgeons place catheters. So you see bleeding with them, especially with the laparoscopic approaches, if they do a mentopexy. There is a study out of the States that showed that if there was bleeding, that if you flushed it till it was clear, your risk of getting adhesions was much lower. But I just, like you, if there's no blood staining, then you want to leave that catheter closed and not manipulate it if you can help it.
Yes.
Excellent. Okay, have you got time for one more question? Well, there's two of these questions I think we'll keep to the end because they probably are going to be answered by Dr. Shah. So I'll hang on to those. The one question was, if you've got fibrin stuck in your catheter, what can you use to dissolve it?
When you see a fibrin in intraluminally, or when the patients are performing the PD exchange, we refer to our PD nurse. Actually, the PD nurse will do flushing with a heparin saline. So they instill the heparin into about 550 cc of syringe, and they flush the PD catheter. We have stopped using streptokinase because I had a very bad experience where some nephrologists, where they flush with streptokinase and it causes peritoneal bleeding, intraperitoneal bleeding, and that will cause adhesion, like you mentioned just now. Whenever there's bleeding intraperitoneally, actually it will promote adhesions. So we do not flush our catheters whenever there's clot or fibrin with streptokinase, but we only flush with heparin saline. So when we do this, actually it did work. So when you flush it with heparin saline, it does work, and the fibrin will be just removed into the dialysate, and it will not recur. So I'm not sure, Brad, how you manage this. That's how we did it in our center.
Yeah, so we do the same. I do tend to use alteplase, but as you say, it's not flushing it. It's you wanting to lock that line. So we use a very slow injection of 8 mils of alteplase. So basically, you're trying not to get it out the tip of the catheter, but just to fill the catheter, and it can be effective. But I have also seen a patient with some bloodstained fluid afterwards, especially if they try and vigorously flush it. So you flush it, you suck. I have bleeding with that. So I agree with you there. And a last question, just in terms of resting, because it's always a question people have, can you use a PD catheter immediately or can't you? So what are you going to do in a patient with acute kidney injury? So what are your tips for how you can manage a patient who you're starting urgently or acute PD?
Okay, so we in our center, we do perform urgent start PD, especially in patient with vascular access, exhausted vascular access, and very challenging. They have we can't put any more hemodialysis catheters in. So the urgent start PD that we use, where we use immediately, even 24 hours post-operatively. And we have a regime where we perform the urgent start PD in terms that the patient lies supine most of the time during the PD exchange, and we instill very small volume of dual volume, where we start with 500 ml first, and slowly by the second day or third day we increase to 800 and 1 liter, and by the 1 week only we go beyond 1 liter to 2 liters. And we try to avoid we tell the patient to avoid from coughing or straining. So to avoid constipation, we give regular lactulose. And in some some hospital where APD is available, we put the patient on cycler, where most of the time the patient will be supine to reduce intra-abdominal pressure. But in centers where a cycler is not available, you can continue with a CAPD, but a very low volume. We did an audit when we did urgent start PD in our center. It was about 20 patients, and we noticed a pericatheter leak was higher in elderly, and another risk factor is in a patient with a high BMI of more than 30. So the lean one, there were no leaks, but those are the two risk factor when they develop catheter leak. So the issue of urgent start PD is mainly the leaks.
I mean, in terms of acute kidney injury, I mean, we, with the ISPD guidelines, we actually recommended up to 2 liters, although in your patients, that would be about 1.5 liters. But as you say, we always say that they should be supine if possible, not getting up if the abdomen. You showed those slides, looking at abdominal pressure. You did talk about pericatheter leaks with a midline incision, and that is taught a lot, but certainly that is the case with surgically placed catheters where you're making incision in the midline. With the Seldinger technique, we see it very seldom that they get a leak around that. I think because you just dilate along through that linear elbow. So people mustn't be put off using the midline if they are doing a Seldinger technique, but avoid it if you're doing it surgically. But yeah, you've got an amazing program, and thank you so much for all of your insights. It's a huge inspiration to everyone here in Africa. You know, we're so excited about getting PD going.
Yeah.
We're very much in the infancy, and so knowing that you've started a program and built it up to what you have is amazing. So thank you very much for coming to talk to us.
Thank you very much.
So I'd like to introduce Professor Ankur Shah, who's an Associate Professor of Medicine and Director of Clinical Research, as well as the Associate Fellowship Program at the Warren Alpert School of Alpert Medical School, at Brown University. He also is the Director of the DeVita North Providence Peritoneal Dialysis Program, and his expertise is in home dialysis as well as the environmental impacts on kidney disease. He's published widely, as well as is an editor, associate editor with PDI and Clinical Nephrology, and he's served on editorial boards for most of the large nephrology journals, including ASN, JASN, KSAP Plus One. He's also a keen educator and has won a number of awards for his education. He's won the Dean's Excellence Teaching Award, the Department of Medicine Teaching Award, the Nephrology Fellowship Teaching Award at Brown University, and is a past winner of the American Society of Nephrology's Innovations in Kidney Education contest. So huge respect for Dr. Shah, who not only knows how to treat patients on PD, but is an educator and is going to talk to us today on how to write a prescription. So thank you.
Thank you for having me. Thank you for the kind introduction. And also, I will say, following up that amazing talk is going to be a little difficult, but I will do my best. So I'm going to talk about prescribing high-quality, goal-directed peritoneal dialysis. And I should preface by saying that I want to provide just as much of why as how. And I am going to move a little bit quick. So here are my disclosures. And I want to start by giving some of the sources that I use as kind of my guiding documents. And I use the ISPD guidelines for prescribing high-quality goal-directed peritoneal dialysis to really help guide what I do. And in fact, I just want to share the ISPD guidelines really are my guiding documents across the board. I strongly recommend anytime you have a question related to really anything related to peritoneal dialysis, that the ISPD guidelines are an excellent place to go for guidance. And I also want to share that there was an article published by Edwina Brown and Corbett in 2024 that I think is a really great complement to the ISPD guidelines, and it really goes through their recommendations for delivering person-centered peritoneal dialysis. And we'll go into a lot of what they say here, but I think that the big picture that I first want to start with is the importance of truly a global perspective. And maybe I'll start initially with peritoneal dialysis in general, because I think that a lot of us are familiar with hemodialysis. And so I want to just start with the big picture of peritoneal dialysis. With hemodialysis, you have a blood flow, a semi-permeable membrane, and a dialysate. And we essentially do the same with peritoneal dialysis. We take advantage of the fact that you have a natural semi-permeable membrane in your peritoneal membrane, and we add an external fluid, dialysate, into your peritoneal cavity, and then you will have diffusion and convection of solutes. Interestingly, some of the early research into hemodialysis, Nichols in the 1920s, actually you could consider to be a hybrid of dialysis, because some of the early 1920s, 1930s in vivo and in vitro experiments of hemodialysis, the dialysis filter or membrane that they used was actually cow and sheep peritoneum. So PD and HD grew together and then eventually grew apart. And so, as I mentioned, the peritoneal membrane lines the walls of your abdominal cavity, encases your internal organs, and it is a semi-permeable membrane. And you have a blood flow to your peritoneal cavity of about 60 mLs per minute. So when you have a blood flow, you've got a semi-permeable membrane. If we add a dialysate, we have all the components that we have to that hemodialysis that we are comfortable with, and we can then perform peritoneal dialysis. And I want to start with how I used to prescribe PD, because as you look into literature on the prescription of PD, some of what you will find is going to look relatively similar to this. What I used to do is I would be very urea-centric. I would take the patient's weight, try to determine their volume and distribution of urea, and then determine urea kinetics to figure out how much PD to give them. And we don't do that as much anymore. And I want to reflect a little bit on why PD prescribing practices have changed. And in the US, I'm forced to do that. We have regulations in the United States that require me to target urea kinetics. But thankfully, that's a me problem. Really, what we should be targeting is a much broader perspective. We should be targeting adequacy in general. And that includes things like functional status, social goals, patient-reported outcomes, thinking about things like residual kidney function, which does fall into a little bit of those urea kinetics, thinking about volume status, blood pressure, cardiac geometry, how is your patient's mineral bone, anemia, moving from some of those elements, thinking about what our patients' goals of care are. Are their goals to improve survival? Are their goals to extend time on PD therapy, increase their quality of life? So there is a very, very broad perspective of what dialysis should be. And in the US, we really love this term adequacy. And I think it's an important term because nobody wants dialysis to be adequate. We want to be thriving, not adequate. And I think that what I'm showing you here is a method to get to dialysis adequacy. And I think using a more global perspective is a way to get from adequacy to thriving. And so what do our patients care about? This is what we should think about when we are designing our PD prescriptions. My patients care about avoiding infections. They care about staying alive. They care about technique survival, staying on PD. They care about what life is like for them. They care about not getting cardiovascular disease. I have never had a patient come to me and say, my goal is for that KT/V number that you share with me to be some number. But these numbers will vary by country. In the US, surprisingly, mortality is actually lower. It's around number 8 in terms of all of these outcomes. In other countries, it's different. And so the real thing that I would like to highlight about prescribing PD is the importance of goal-directed PD. I have patients who are on PD with the goal of getting to their grandchild's wedding. I have patients who are on PD with the goal of being alive for the next 50 years. The way I prescribe PD to both of those patients is different. And there are options in how I can prescribe PD. Part of the reason I'm spending so much time on the why, and I will get to the how, but a little bit less time on the how, is because there are not right or wrong options. There are just options. There is not evidence that says that any of these options I'm going to share with you are going to be better than others. I think there were some questions earlier about which is better between PD and HD as well. And that too, the literature, there's a lot of literature that has compared PD to HD. And when you look at that literature, what you'll find is that inevitably it's all about the patients you select. Once you can get away from that selection bias, what you will find is that there really is not a difference in outcomes between PD and HD. And so what is best is probably what is best for your patient, at least in hard outcomes like mortality. There is a difference in autonomy, flexibility, life participation, quality of life that favors PD. With PD, there are 2 ways that PD can be prescribed. One would be automated PD or APD or CCPD. The other would be manual PD or CAPD. And so we will briefly discuss each of these. For CAPD, this is done manually. You use gravity to instill the dialysate and you use gravity to drain the dialysate. Typically, you will use a hypertonic dextrose solution. You'll let it dwell for 4 to 6 hours and then waste that solution. That solution over those 4 to 6 hours will become saturated with uremic toxins, with potassium, with all the milieu that we're trying to get rid of. And we use gravity to let the fluids flow in and out. Clearance is achieved through diffusion, convection, solvent drag, and that dextrose creates that osmotic pressure that gives you that water removal. Automated PD works a little bit differently. Automated PD will use a machine called a cycler, and the machine will do shorter dwells overnight. The idea between automated PD is to keep your day available for life participation, but with automated PD, what you have is a decrease in efficiency because we do not let the fluid stay there long enough for it to get fully saturated. So you use a machine called the cycler that will put fluid into your peritoneal cavity, let it sit there for a certain period of time, and then drain it. And it will rinse and repeat and do the entirety of the procedure for you. And it can also instill fluid for the day. So the way that this will look can be variable based on the patient. For CAPD, what you can see here is someone who at 7 a.m., they put fluid in, it stays until noon, they drain and then replace it, it stays until 5 p.m., they drain and replace it, it stays until 10 p.m., then they put in fluid and go to bed. I would think of this as someone who does an exchange when they wake up, at lunch, after work, and then right before bed. The second example that you see is someone who is using a cycler, but they're not using any dialysate during the day. They're doing 4 exchanges overnight. Each exchange is about a little over 2 hours. And so they're getting their dialysis out of the way while they're sleeping. The third is that person has added an exchange during the day. So they're getting these short, rapid exchanges overnight, but they're not getting the benefit of time on PD. They're not getting those middle molecules cleared. They're not getting their phosphorus cleared. So they add a dwell for long dwell during the day. The fifth may be someone who says, I need a little bit more clearance, but I really don't like walking around with dialysate in all day. So they're doing 4 exchanges overnight. The cycler is putting fluid in, and then they're manually draining it. And then the next one would be potentially someone who needs a very high dose of PD. The largest patient who I've had on PD was well over 100 kilograms. And he, even with 4 or 5 exchanges overnight and fluid during the day, it was not enough to clear all of his uremic toxins. And so he remained mildly uremic. And the way that he reached thriving was with an additional dwell. There is something called tidal PD that I'm not going to get into very much, but tidal PD is essentially saying we're not going to fully drain between each exchange, because sometimes draining to fully empty can be painful. You do have a catheter in your peritoneal cavity, and if you fully drain, that catheter can irritate your peritoneal organs and viscera. And so sometimes we'll use something called tidal, where we'll leave a little bit of fluid behind. But the reason I use this example is, you see in this last example, this person is doing 8 exchanges in about 8 hours. And I thought it was a great segue into the problem that can happen if you tried to do 8 exchanges over 8 hours. And the problem that can happen is something called sodium sieving. And the general gestalt of sodium sieving is that your peritoneum has different size transporters. And when we first introduce hypertonic glucose into and dialysate, we get an osmotic gradient. And initially, we get water before we get sodium transport. So initially, what you will see is that the sodium concentration in your dialysate will go down. You have water that will go from the blood into the dialysate. And so your serum sodium will go up. Your dialysate sodium will go down. And as that serum sodium goes up, if you were to stop this dwell at 1 hour, we have not gotten very much sodium efflux. We have really just dialyzed out water. And so now my patient will be thirsty, because they are now relatively hypernatremic. And with that thirst, they will drink. And so we want to make sure that our dwells are not too short. I would say aim to keep a minimum of 1.5 hours for each dwell time, maybe 1 hour, 15 minutes. And that will give your patient enough time to equilibrate, have the sodium efflux as well, and not have complications of sodium sieving. I have mentioned earlier APD versus CAPD. I just want to show you a little bit of literature. This was a meta-analysis of 198,000 PD patients that looked in an intention to treat subgroup of the mortality risk between APD and CAPD and showed no difference. And so this would support that you can do what fits best into your patient's lifestyle. One of these is not superior to the other. There are many similar, looking at HD versus PD, and you will find some studies that show differences, but largely those are selection biases. The solutions that we use dextrose as a hypertonic solution to remove fluid. And so you can vary that by the amount of fluid you want to remove. If you have someone in pulmonary edema, you want to use higher dextrose concentrations. I will tell you what icodextrin is in the next slide, so we can just wait on that one. And the electrolyte content is a little bit different from hemodialysis. I heard a little bit of discussion earlier on sources for dialysate and supplies. And so this may be a little bit different based off of where you get your dialysate. But in the US, we have Baxter and Fresenius as our 2 large vendors. And those 2, their electrolyte contents are sodium, typically 132, 0 potassium. There's no option for potassium in dialysate. 0.5 to 1.5 mag, chloride that varies a little bit. Lactate is your primary buffer, 35 to 40, and you can have a lower or standard calcium bath, 2.5 or 3.5 milliequivalents per liter. Icodextrin that I said I would tell you what that is. It is a glucose polymer that's used as an oncotic agent. And essentially what this does is it provides sustained ultrafiltration over extended periods. If I put hypertonic glucose into your peritoneal cavity and I let it sit there for 8 or 10 hours, you will absorb that glucose. The osmotic gradient will dissipate, and so you will begin to absorb the fluid. This, as a polymer, will be minorly absorbed. It can be absorbed slightly via lymphatics, but it will remain there and give you that sustained ultrafiltration and also reduce your glucose absorption and potentially metabolic complications. I do want to highlight that while the name of this talk was how I prescribe PD, if you had a different speaker, you may find a very different answer. Here's some PDOPS literature looking at how PD is prescribed. In the US, we like machines. We like gadgets. We use the cycler for 83% of our patients. If you had a Japanese or Thai speaker, they are 63% and 95% manual PD. So there is a lot of variation. And even within each PD prescription, there is a lot of variation. In the patients who receive manual PD, if you look at Japan, the dwell volumes are largely 2 liters. In the US, they're largely greater than 2 liters. The prescribed total volumes are larger in the US than in many other countries. There's great variation in the number of exchanges. So there are many ways to prescribe PD. I think that if there was one right answer, you would see a lot more homogeneity amongst the data that I'm presenting to you, but you see a lot of heterogeneity. You also see here in terms of cycler prescriptions, again, lots of heterogeneity. Differences in dwell volumes. The US uses much larger dwell volumes than other countries. The US uses much larger day dwells. The US uses much lower rates of day dwells than some countries. Thailand uses dry days much more than the US does. There's a lot of variation. And this is also showing, going into that glucose solutions, the US uses hypertonic solutions much more than other countries. So as a speaker from the US, I may be giving you a bit of a biased perspective. What we do is very different from what many other countries do. And so what you may find is that as PD rolls out, that what you do we may need to add another column here and add more data. And in terms of what we do and how I choose what I do, I start with certain principles. So the first thing I need to do is, when starting PD, I need to think about my patient holistically, because PD, no matter what I do, it's not going to impact their mortality, but it will impact their life participation. And I can't target life participation if I don't know about life. So I need to know about your lifestyle, your work schedule, your support system. Oh, I need to start moving quicker. So I'm going to just skip ahead a little bit to how I prescribe PD. So I start with a patient's daily schedule, routine, and goals, and I work backwards. So to give 2 quick examples, or we'll use 1 quick example, I'll use a college student. These are things that I tend to ask patients when I'm trying to put together a PD prescription. What is your work schedule? What's your sleep schedule? Who's at home with you? Are they helping? What do you like to do? Do you exercise? Do you have pets? Is travel a thing in your life? What other comorbid conditions do you have? I don't ask, by the way, I consider they're obese, whether they are obese, whether they have residual kidney function, and I ask them about storage space. The variables that you can assign for someone who is doing manual exchanges, the number of days that they're doing dialysis, how many exchanges they're doing and when they're doing them, how much volume they're using, and the solutions. If they're doing automated, you can assign the number of days they're using the cycler, how long they're on it, how many exchanges, how much fluid you're using, and what they're doing during the day. Things to consider, but that I can't assign, are residual kidney function. So I'll give an example here of a 22-year-old female. Actually, I'm going to use the next example of the accountant. So this is a 38-year-old gentleman who had stage 5 CKD, hypertension, came in with nausea, vomiting, dizziness, found to have CKD, had no improvements. And so we did CKD education, and he was interested in home dialysis. He works as an accountant. Maintaining his work-life balance was extremely important to him. So I just went through all of these with him. What is his work schedule? He works about 9 to 5, but he works from home. He sleeps 11 to 6. Only sleeping 7 hours at night, I wasn't very enthusiastic that the cycler is going to be what makes sense for him. Very strong family caregiver support. He doesn't have hobbies that are going to affect PD. He does daily cardio. No pets. Travel is really important to him. In terms of comorbidities, he's had 2 failed transplants, no obesity, plenty of storage space, and his residual kidney function is rapidly declining. So as we tried to put together his PD prescription, the things that stuck out to me were that he works from home. He has some flexibility in what he does. He does not sleep a great amount of time. And so if I asked him to connect to a machine while he's sleeping, I'm not sure I can get all the PD that he will need, because I don't think he's going to have his own kidney function for very long. And I don't see a lot else here except for that failed transplant ×2. He's not a large gentleman, so I'm a bit worried that I'm not going to be able to use very large dwell volumes because he might start getting overfill symptoms. So I'm worried about time overnight. I'm worried about dwell volumes overnight. So what I did is I told him, let's do PD every day. We're going to do 3 exchanges during the day, 1 at night. We're going to do low dwell volumes. 1.5 liters is a relatively small amount for a gentleman. And we're going to do 9 a.m., 12 p.m., 5 p.m., and bedtime. So he's going to do right before he goes to work. I wanted him to do it earlier. There were some other things that this fit better for him. He's going to do it when he starts work, his lunch break, after work, and bedtime. And this worked out really well for him because this fit into his life very well. I will be honest, when I heard he worked full-time as an accountant, I thought he was going to want to do his PD overnight. I thought he was going to be a cycler patient and he's going to want his days free. He wanted to do this during the day, and so we fit it in during his day, and this actually worked out very well for him. He was on PD for about a year before getting another transplant. And so in terms of things, that's how I start. In terms of how I adjust, I look for things that tell me that PD is not going well. I look at patient well-being, volume control, solute removal, blood tests, hyperkalemia, hyperphosphatemia, low bicarbonates, worsening uremia. I look at energy levels. I look at symptoms. And so I look at essentially the things that we do when we're deciding to put someone onto dialysis. And if I find that someone is under dialyzed, I increase their volume. I take those dry periods and I add dialysate into it. I may increase time. I may add exchanges. I may add icodextrin, or I might change tonicity. I'm sorry, I moved very quick. My invite ended at 1 p.m., so I had this scheduled a little bit differently. But this is our division at Brown University. At the bottom are my research funders. So thank you for having me, and I would love to answer a couple questions.
Thanks very much, Ankur. Fantastic talk, and I'm sorry if you can stay on for a few questions, that would be
Absolutely.
amazing.
I could stay on for like 3 or 4 more minutes.
Okay. So just a quick question. In Africa, CAPD is generally the only option in many places. How would you manage a patient who, for example, was a high transporter who might benefit from APD if CAPD is your only option?
So I think if I had someone who is a high transporter, there are a couple of things that I've done. I have a few patients who are high transporters who just do not like the cycler. So even though I have it available, they do not want it. This is off-label. Baxter says that you can only use icodextrin once a day, but you can try using twice-a-day icodextrin where you'll get around that rapid absorption. You can ask them if they'll do twice-a-day icodextrin plus 1 or 2 very short exchanges that will help with volume removal. So sometimes what I will do is I will say, if you can do 2 manual exchanges in 4 hours, it may not be your favorite 4 hours during the day, but that will help us. And then we can use ICO to get through the rest of the day. So I will use a combination of multiple times a day icodextrin. And if I need 2 short manual exchanges, I'm not a huge fan of short manual exchanges because it's a lot of burden on a patient, but that's typically the way that I try to get around that.
And what's your feeling about incremental PD?
So I am a big fan of incremental PD. I did not include very much on it here. The idea of incremental PD is that you can offer PD in one of 2 ways. You can say, here is all the PD you're going to need, and so we are going to give you everything. Or you can say that you don't need everything right now. If you start dialysis with a GFR of 8, the next day you still have a GFR of 8. And typically when we start patients on dialysis, we start them at either their first solute indication or early uremic symptoms. So they do not need a full dose of PD to get back to the quality of life they're looking for. The other example that I was going to use was a patient who I had them doing dialysis 5 nights a week. I had them using a full prescription for those 5 nights, but this was a college student. She wanted to be partying with her friends on Friday and Saturday. And so I told her, I'm going to use every ounce of the 5 days you're going to give me, but you take those 2 days off and you enjoy your normal life as a college student as best you can, unfortunately having to do this on dialysis. The one downside to PD or to incremental PD is when you need to make those increments, it can be difficult. And the reason it can be difficult is you need to convince your patient that what they've been doing needs to increase. I find that I try to tell them early what they're going to expect in the future. That works sometimes well. I have sometimes, if I have a patient who I think it's going to be difficult, I do decremental and then incremental. So I start them on full PD for a couple months, then move to an incremental prescription and say, we've gotten you out of crisis, we've gotten you out of hyperkalemia, out of hypervolemia. Now we can get you to a more quality of life related prescription, but as you lose your residual, we'll have to go back to what we started with. So I have done kind of decrement, then re-increment. I think it's really great for patients. If you do not need more PD, I don't think you need to do more PD. the more PD you do, the more glucose exposure you get, advanced glycosylation end products, peritoneal damage, and also the more burden on you.
That's fantastic. I think you've summed it up very much, that prescribing PD is about the patient, not about the numbers. And I think that's something that's so important, something that we have to remember, that we're looking after patients. We're not, it's not about numbers. And thank you for an amazing talk, inspiring us all. I'm sorry that we've kept you.
Oh, no, this is absolutely my pleasure to be here. Thank you.
Thank you so much. So there are one or two other questions. I'm happy to just in the last 5 minutes just to try and answer some of those. So one of the questions has been, what determines clearance in PD? Clearance is determined either by your removal of urea or other uremic toxins. You need to remember that urea moves very quickly. Larger molecular weight toxins like beta-2 microglobulin, phosphate, they move very slowly. So we need to try and ensure that we actually get clearance of all of those. Residual renal function is very important. It contributes to your clearances. So if you've got good residual renal function, your need for watching clearance is much lower. But in your anuric patients, measuring a KT/V in a patient that you're concerned about can be helpful to say, look, they are getting a decent dose of dialysis. And as Ankur said, this KT/V of 1.7, which you can measure, and you can actually measure the urea clearance. That at least is a ballpark, somewhere that you can say, I'm not sure if this patient's getting enough dialysis. Let's measure it. Okay, yeah, we're in the right ballpark. But remember that KT/V of 1.7 includes your residual renal function. So if they're passing good volumes of urine, you want to measure the residual renal function and urea clearance, as well as the peritoneal clearance, and add those together. There's a question on, or there have been a number of questions on which is better, PD or HD. As Ankur said, there have been a number of studies that they've tried to do randomized controlled trials, and the problem is, as soon as you randomize patients to HD or PD, patients don't want to be told what they're going to do. So there've been a number of trials that have started and have never finished because people choose which modality they want to go on to. There's registry data from many places around the world showing that PD and HD are equivalent. There's some studies showing PD is actually better in the first year, but it is related to selection bias. What I say to my patients is that I believe that they're equivalent, and what you must do is choose your dialysis modality on what's going to suit your life. Very much what Ankur was saying. You need to look at what's going to suit the patient's life, but in terms of the dialysis quality, they are both as good as each other. A final question was on advice on fluid improvisation for centers that don't have access to manufactured PD fluid. Improvisation is difficult for chronic PD. I think you are likely to run into trouble if you're trying to make solutions for a patient doing chronic PD. That may change in the near future. There's the Ellen medical device, which is a device where you actually make up your solutions at home using a solar panel device, but that probably won't be available for a number of years. So manufacturing fluid for patients doing chronic PD, I would avoid. Having said that, for acute PD, that's a very different story. These patients are only doing dialysis for 6 or 7 days. It's being done in a hospital setting where you can do it in a sterile manner. And if you look at the ISPD guidelines for PD and AKI, there's actually a very nice recipe there where you can use glucose and Ringer's lactate or Hartmann solution to make a solution very similar to commercially produced solutions. And we've got a number of studies out of our Saving Young Lives sites, as well as a study from Cape Town showing that peritonitis rates were equivalent using improvised solutions. So that's a great option. So I think we are up to time at 7:30. So I'm not sure if there are any other questions, or if Mushahar, if you have any questions or comments you'd like to make before we close this webinar, which has been fantastic, and fantastic speakers.
Thank you, Dr. Kallis. Clearly, it was a very nice presentation. Unfortunately, Our second presenter was pressed for time, but hopefully we can get him on some other day to give us a better and more in-depth talk. Thank you very much for moderating this session, and I think it was very informative and fairly basic for a non-nephrologist as well to understand. So I think it was quite great. Dr. Lloyd, perhaps if you have any closing remarks.
Grateful to the ISPD for actually, helping us organize this session, not only this, but the previous one as well. Thank you, Dr. Kallis, for this wonderful moderation and the questions and, emphasizing on the important aspects of the session and the talks and the questions. We really look forward to your support to help us go through PD here in the region, because you're a master in PD in the region and close to us as well. So we really look forward to your support. Thank you very much for being here and really being here despite of your busy schedule. And you've been traveling and just come back yesterday, I remember. Thank you so much. Thank you very, very much.
And thank you, and good luck to all of you setting up your PD programs. It's a hard job getting people won over to PD, but it is so rewarding when you actually see the benefits to patients and the number of patients who, when you then have to change them over to hemodialysis for whatever reason, that you realize just how important it is to them. So congratulations and good luck.
Thank you so much, Dr. Kallis. Thank you very, very much.